All right, let's jump right into our deep dive on Lyme disease. If you're prepping for your Canadian Pharmacy Board exams, trust me, this is a topic you absolutely have to know inside and out. So let's get you ready.
Okay, here's our game plan. We're going to start with the absolute basics, then get into how the disease actually shows up in patients and how we diagnose it. We'll spend a good chunk of time on pharmacotherapy. That's going to be huge for your exam. And then we'll finish up with prevention and handling cases in special populations.
First things first, let's build that solid foundation. What exactly is Lyme disease? How do people get it? And where are the biggest risk areas in Canada?
So, at its very core, Lyme disease is a bacterial infection. The culprit here in North America is a cool-looking corkscrew-shaped bacterium, a spirocate, called Borrelia burgdorferi, and it gets into humans through the bite of a specific vector, the black-legged tick. You'll see it called Ixodes scapularis or Ixodes pacificus. This map right here gives you a really clear visual of the high-risk zones. You can see these hotspots in southern BC, southern Manitoba, Ontario, Quebec, and then out east in New Brunswick and Nova Scotia. And what's really important to remember is that these risk areas are expanding. This isn't a static problem. It's a growing public health concern all across the country. You know, the way this whole thing works is pretty fascinating. Ticks pick up the bacteria from little critters, like mice. But when an infected tick bites a person, the transmission isn't instant. The spirochete actually has to travel from the tick's gut to its salivary glands, and that journey takes anywhere from 36 to 72 hours. That time window, it's absolutely critical, and we'll come back to why that matters so much when we talk about prophylaxis.
Okay, so how does this infection actually look in a patient? Recognizing the signs and symptoms is, of course, the first big step to managing it properly.
This right here is the classic telltale sign of early Lyme disease. It's called erythema migrans, or EM for short. It shows up in about 80% of cases, usually a week or two after the bite. It starts as a red spot and just keeps expanding until it's at least 5 centimeters across. Now, we all think of the classic bullseye, but it can also be just a solid red patch. And as you can see, how it looks can really vary on different skin tones, which is a super important point for diagnosis.
For your exam, you've got to be able to tell EM apart from other common skin issues. Think of this table as your cheat sheet. Unlike cellulitis, EM usually isn't tender and has really clear borders. It doesn't have the scaly edges of ringworm or tinea corporis. And this is a big one. A simple allergic reaction to the bite happens almost right away, and it doesn't grow bigger over several days like an EM rash does. Now, if you don't treat it, the infection moves through these distinct stages. It starts as early localized disease, which is when you see that EM rash. Weeks or months later, it can become early disseminated. This is where it spreads and starts affecting the nervous system. We're talking facial palsy or meningitis, or even the heart, causing an AV block that messes with the heart's rhythm. And if it's still not treated, you get to late disease months later, which often looks like arthritis in a big joint, like the knee.
So, we know how to spot the symptoms, but how do we actually confirm a diagnosis? This gets really important once the disease has spread beyond just a skin rash.
This is a classic exam-style question. So what's the right move? Can you just go by the clinical signs, or do you need to get the lab involved?
Well, for disseminated or late disease, the answer is this 2-tiered testing algorithm. Let's walk through it. First, you start with a screening test that's very sensitive, usually an enzyme immunoassay, or EIA. If that's negative, you can pretty much rule out Lyme. But if it comes back positive or even borderline, you go to the second tier. That's a more specific confirmatory test called an immunoblot or Western blot. This whole 2-step process is designed to be as accurate as possible and cut down on false positives.
Okay, this is a huge takeaway. You need to know when to test and what the results actually mean. If a patient comes in with that classic EM rash and they're in a high-risk area, the diagnosis is clinical, period. You should not order a blood test because it's very likely to be a false negative at that early stage. But as the disease progresses, the test gets way more sensitive. And one last critical point for your exam, antibodies can hang around for years. So a positive test doesn't prove it's an active infection, and you absolutely never use it as a test of cure. All right, let's get to the heart of it for us as pharmacy professionals, the specific treatments for each stage of Lyme disease. This is super high-yield stuff for your exams, so listen up. For a simple, straightforward erythema migrans rash, oral antibiotics are fantastic, with cure rates well over 90%. As you can see, our first-line choices are doxycycline for 10 days, or amoxicillin or cefuroxime for 14 days. Azithromycin is there as a second-line option, maybe for someone with allergies, but you have to remember its efficacy is a bit lower, sitting at around 80%. Now, this is really interesting. There's been a bit of a shift in how we treat neuroborreliosis. That's when the bacteria gets into the nervous system. For an isolated facial nerve palsy, you're looking at oral doxycycline. But for more serious stuff like meningitis, the old school approach was always IV ceftriaxone. Now, though, the guidelines reflect a ton of evidence showing that for many stable patients, oral doxycycline for 14 to 21 days works just as well. That's a huge deal for avoiding the risks and costs of IV therapy.
For these other disseminated forms, the treatment duration gets longer. For mild carditis, you're looking at oral agents for 14 to 21 days. But here's a key clinical trigger. If a patient's ECG shows a PR interval of 300 milliseconds or more, they need to be hospitalized and put on IV ceftriaxone. And for Lyme arthritis, the standard course is even longer, a full 28 days of an oral agent like doxycycline.
This is a critical counseling point, so please remember this. About 15% of patients will have something called a Jarisch-Herxheimer reaction within a day of starting antibiotics. It's basically an inflammatory response to all the bacteria dying off, and it can cause fever, chills, and muscle aches. You have to warn patients this can happen. Reassure them it means the treatment is working, it'll go away on its own, and they can manage it with NSAID.
Okay, what about those patients who still feel unwell, fatigue, pain, even after treatment? This is often called post-treatment Lyme disease symptoms. It's so important to understand the official stance here. The guidelines are clear. There's no evidence this is an ongoing infection. Multiple major studies have shown that giving more and more antibiotics doesn't help and can actually cause a lot of harm. The right approach is supportive care.
Let's shift gears to prevention. This is an area where pharmacists can make a huge difference, just through patient education and counseling, when someone comes in talking about a tick bite.
The very first line of defense is getting that tick off correctly. You want to use fine-tipped tweezers and grab the tick's head right where it meets the skin. Then pull straight up with steady, even pressure. Don't twist it or jerk it. That's how the mouth parts break off in the skin. And once it's out, give the area a really good cleaning.
This algorithm is your best friend when someone asks, I got a tick bite, do I need an antibiotic? This is post-exposure prophylaxis, or PEP. Let's trace the logic. First question, was the tick engorged? Meaning, was it attached for over 36 hours? If not, no PEP needed. If it was, the next question is about time. Did they get it off less than 72 hours ago? If yes, and they meet some other criteria we'll talk about, then a single dose of doxycycline is an option. If it's been more than 72 hours, it's too late for PEP, and they just need to monitor for symptoms.
Let me be crystal clear. PEP is not for every tick bite. You should only offer that single 200 milligram dose of doxycycline if, and only if, all of these very strict criteria are met. The bite has to be from a black-legged tick. It had to be attached for at least 36 hours. You have to be able to start the antibiotic within 72 hours of removal. And the bite has to have happened in a high-risk area where tick infection rates are over 20%. If even one of those isn't true, the recommendation is to just watch and wait.
And finally, let's touch on managing Lyme in pregnant and breastfeeding patients. This stuff is always high yield for your board exams. This is a really powerful and reassuring statement from the guidelines. When you're counseling a pregnant patient who is understandably worried, you can tell them that with proper treatment, there are no documented cases of the infection being passed to the fetus and no link to bad outcomes. And there's also no evidence it can be transmitted through breast milk. So the treatment approach does change a bit during pregnancy. Doxycycline is a no-go for treatment because we have safer alternatives. For mild, localized disease, the drugs of choice are amoxicillin or cefuroxime. And if it's a severe, disseminated case that needs hospitalization, IV ceftriaxone is what you'll use. And that's a wrap on our detailed look at Lyme disease. The big takeaway here is that as these tick habitats continue to expand across Canada, our role as pharmacists is really evolving. Your expertise in prevention, proper tick removal, and knowing those strict criteria for prophylaxis is more crucial than ever. Keep these points top of mind for your exams and for your future practice. Thanks for tuning in to this explainer.